Yeah. All right, let me introduce you. Dr. Baek, she's a partner at California Fertility Partners in Los Angeles, where I am, part of the Pinnacle Fertility Network. She's double board certified in OB/GYN and reproductive endocrinology and infertility, and has been recognized by Los Angeles Magazine and Southern California Super Doctors. Beyond her credentials, she's known for her compassionate, individualized care, and I personally know people who have gone to her because they've been friends of mine and they say very, very good things and end up with children often.
Rachel, thank
Um,
you so much for having me. I'm like really excited to be on this with you, and like I'm like really excited that we can kind of navigate this and kind of answer some questions that people may have.
yes, and I have a group of people who have very advanced questions, I would say. So I'm going to get right into it. Number one, for FET, is there a standard number of embryos to transfer based on quality, and when do you ever consider two?
Okay, so it really depends on number one, how old you are, and it really makes a difference in terms of how old the embryo was like, at the age of the egg. And so when it's a younger egg, the age obviously makes a huge age is the number of predictor of success. So if it's a younger egg, the success rates are a lot higher. It also depends on if you're carrying, do you have any medical issues or any uterine factors? For example, do you have a history of endometriosis? Do you have a history of any obstetric complications, reproductive loss? Do you have any fibroids? That really makes a difference. So really, I recommend oftentimes that people consider a single embryo transfer because you could have a perfect uterus and you could have had a completely normal full-term vaginal delivery in a previous pregnancy. But with any pregnancy, especially a double embryo transfer with twins, you can never predict who's going to have preeclampsia, gestational diabetes, preterm labor, intrauterine growth restriction. And because of those complications, that's one of the things I always look at. I also look to see, do they have any medical issues or any uterine factors? Because the last thing you want to do is anyone who already has a history of uterine surgery or fibroids or a correction of a septum, those patients are already at an increased risk of miscarriage, no pregnancy, and obstetric complications. So in those patients, I really would advise against twins. If you're transferring two genetically normal embryos and you happen to have everything's like perfectly normal, you can't predict if one may miscarry. And if one miscarries, you're always at a higher risk of losing both. And so, given all those different factors, I don't think there's a straightforward yes, in this situation, I would do a transfer. It's really patient dependent. I recommend that everyone really consider a single embryo transfer to give them the best chance of having an uncomplicated, healthy delivery. But there are times I will consider embryo transfer, especially if everything else is perfect in terms of their uterus.
Okay, thank you. How many embryos should someone plan to bank for the best odds of one live birth at different ages?
Okay. One of the first questions I ask whenever I do a new consult is how many children do you want? And the reason I ask that question is I always work backwards into how do I help you meet your fertility goals? So it depends on how old the patient is, what their reserve is, if there's a male factor, uterine factor, and how many embryos we're working with. So if someone is 35 and they want to transfer and they want to have two children and everything else is perfectly normal, they have perfect sperm, the uterus is normal, the tubes are open, we may consider banking one, two embryos for baby number two and then helping them get pregnant naturally with baby number one. But if they tell me, I want to have children until I'm 38 or 40, to be cautious, I would recommend that we try to bank at least two embryos, two euploid embryos for every child they want for the future. If they have any uterine factors, like we know that they have adenomyosis, which is endometriosis in the muscle of the uterus, or they have endometriosis or any other medical complications, in that scenario, that's when I'm a little bit more conservative with the number of embryos that we should bank before we for the first child. Does that make sense?
Yeah, no, that makes a lot of sense. AMH is near zero. What strategies still move the needle and what is false hope?
Okay, so an AMH of less than one does not mean your egg quality is poor, does not mean you're not going to get a normal embryo. You could be a young woman with lots of follicles, but your AMH is really low. So what that tells us is you have a lot of eggs that if we were to try to retrieve, we would retrieve a lot of eggs at that time. It's just that your ovarian reserve for the future is less. So I really try not to use an AMH number alone as a number that kind of scares people into doing treatment. I really look to see, okay, just because your number is low, it doesn't mean that you are going to have poor quality eggs. And let's first figure out how many follicles you have. Is it age appropriate for your age? So if you're under the age of 35, ideally like to see about 15 to 40 follicles. I like to see, are you ovulating properly? Yes or no? I also like to figure out, why is your AMH low? Did you have uterine surgery? Were you born with a lower number? Do you have a genetic reason? Do you have a history of a pelvic infection? Do you have an autoimmune issue that aged your ovaries more quickly? Do you have endometriosis? So you first have to find out, why does someone have a lower number? And that makes a really big difference. But if you have a lower AMH and you look at the ovarian activity and someone is younger, I still think that if you bank embryos, you still will, they have just as good a chance as anyone else their age of having a genetic child. If they had a lower number and they were to try to conceive naturally, and the sperm is normal, the uterus is normal, and your tubes are open, your chance is just as good as anyone else your age. So don't let an AMH make you panic into doing IVF. But if you said, I really want 3 to 4 children, and I'm 35 and my AMH is less than 1, then clearly I would recommend banking embryos for baby number 2, 3, and 4. And based on your history and your physical findings, decide whether or not we can help you conceive baby number 1 naturally.
I love that you try to go for the natural sometimes. I think that it's rare to hear that.
Yeah, no, I
Um,
always feel that if you uncover the underlying issue,
mhm.
you can always help people. I've helped a lot of people, unfortunately, conceive naturally if their tubes are open, uterus is normal, sperm is normal, even after multiple failed IVF, because
Wow.
oftentimes people haven't uncovered the underlying cause for why they were having difficulty. And one of the most common causes of a low AMH, when everything else is perfectly normal, they've been told don't have any autoimmune issues, don't have Fragile X, their chromosomes are normal, they don't have a history of smoking cigarettes or pot, they don't have any other indication for why they would have a low AMH, then you're just left with, were you just born with a lower number, or could you have silent endometriosis? If
Mm.
I suspect endometriosis, what I look for are signs. So obviously not everyone has an endometrioma, which is just chocolate cyst, but I look for other signs. So not everyone has pelvic pain when they have intercourse or their periods. So what I look for is everything midline. Everything in our body should be symmetrical. When I place a vaginal probe towards your head, is your uterus midline? I look in both sagittal, which is like in one direction, and cross section, I turn it 90 degrees. Then I look at both your ovaries. Do you have a comparable number on each side? Is your uterus deviated to one side or the other? Are your ovaries really splayed out to the right or the left? And if there's any physical signs that I suspect you may have endometriosis, in that situation, I have you consider seeing an endometriosis surgeon, because if you have surgery in the right hands, addressing the endometriotic implants by an excision endometriosis surgeon, you preserve your fertility and you improve your egg quality. And oftentimes, if everything else is normal, I've helped people conceive naturally afterwards. But you have to know what you're working with first. So that's why the AMH is not a one, and that's not your only decision making point. You have to figure out, why do you have that lower AMH?
Okay. Go out of order because there is some about endometriosis here that I had 2 failed euploid transfers and have since banked several more. Receptiva and Emma Alice now point to endometriosis. How can that coexist? And is laparoscopy the only reliable way to assess extent?
Okay, so you've had 2 failed embryo transfers before the receptiva, and you've never done Depo-Lupron. So in that situation, if I would send you to an endometriosis surgeon who, like I asked, and in California, there's really 4. Like in all of California, there's 4. 1 in Northern California, 3 in Southern California. And I'm very specific about who I refer
Can
to.
you?
And Dr. Cameron Najat at Stanford. Textbooks and the instruments are named after him, and he is a skilled endometriosis surgeon, and he does take PPO out of network benefits. I also recommend Dr. Rayon Elkate in Beverly Hills. He also takes PPO out of network benefits. He is in Beverly Hills and he's excellent. The other 2 surgeons that I recommend, same last name, but they're not married, is Dr. Lawrence Orbach and Dr. Orbach. Dr. Iris Orbach also wrote the book called Beating Endo by Dr. Iris Orbach, and she also did the documentary called Below the Belt that was produced by Hillary Rodham Clinton, Rosario Dawson, and she's spoken in front of Congress, and she's a true advocate for endometriosis. The biggest concern is when you have endometriosis, oftentimes patients will say, oh, my surgeon did excision surgery. But when you look at the report, they really did surface level. And if you don't really excise it and go deep, you're not improving the egg quality, you're not really addressing it, but you're just burning it on top level. And that's when you don't see a real change in the egg quality or barren activity afterwards. It also really makes a difference how old you are when you're addressing it. So if you address it when you're younger, we'll obviously see a more dramatic improvement. When we're older, sometimes it's too late, so start to make an impact.
Mhm. Okay. Cycles are shortening in premenopause. What do you signal for fertility and timing, and what interventions help?
So when that happens, what it usually means is that you're recruiting a lead follicle even before your period begins. So right after ovulation, before your period begins, your body starts to recruit a dominant follicle. And as you know, natural cycle, from a group of eggs, one will grow, one will ovulate, but you lose the entire cohort of eggs. If someone has a shorter cycle, I don't see them with their period start. I actually try to monitor their cycle the month before to monitor when are they ovulating. Just because you're ovulating, it doesn't mean you're ovulating at a good size. If you're ovulating at 20 millimeters and you're older, or you have a shorter cycle, it means you're naturally ovulating an overcooked egg. If you're ovulating an overcooked egg, we know from our IVF data, you're not going to get pregnant because you're not going to have normal fertilization or a normal embryo. So I like to front run that cycle the month before and trigger ovulation at a smaller size. After ovulation, I look to see how many follicles do you have for the following month. And what you'll find is that sometimes your body already starts to recruit that early lead follicle. If that happens, I will try to synchronize you based on, is it a little larger or a lot larger? Estrogen patches or an antagonist injection. Then in your natural cycle, I would follow you, just monitoring you with an ultrasound. And if there's a question mark with blood work, so that I can front run and trigger the follicle at a smaller size. The way we know whether or not we're kind of triggering at a good size when we're doing a natural cycle is to check an estrogen progesterone 1 week after ovulation. Naturally, that follicle you ovulated from should make a good amount of estrogen and progesterone. So if those levels are low and you need supplementation and you're not pregnant that cycle, we know in a subsequent cycle we may need to trigger you smaller. If someone has done IVF before, I always look to see, okay, were there any signs of a post-mature egg? So we could trigger at the perfect size, 17, 18, that's textbook. But for some patients, you'll find that maybe they had a post-mature egg on the day of egg retrieval, there's abnormal fertilization, or the embryos didn't develop well. In that situation, if I were to do a natural cycle the following month, I would apply what I learned from the IVF cycle and trigger them smaller.
Okay. How do you monitor stimulation in patients who previously ovulated early, and what protocol changes do you make?
Well, it depends on how small they are, how many follicles they are, how early do they ovulate. So are we talking about, if we're talking about a natural cycle, then you obviously have to take a look with blood work and you have to do an estrogen, LH, and a progesterone to dictate when they're ovulating with an ultrasound. If it's from an IVF cycle and you know when they ovulated, then oftentimes you look to see, okay, at what size did they ovulate? Because what you'll see is with the blood work, you should always check post-trigger labs. That's one of the things that when I do second opinions, I'll find that sometimes patients don't check estrogen levels post-trigger. The reason that's really critical, it's the follicles that make the estrogen. So post-trigger, if your estrogen drops by more than 30%, maybe that's a sign, that's a cycle that you may not consider proceeding with. You may have ovulated, or maybe your eggs were post-mature, and in that sign, we may want to trigger you 1 day smaller. If that happens before I proceed with the retrieval, in the operating room, I will tell the patients before they have anesthesia, we're going to do a bedside ultrasound. If there's any sign that they ovulated, I cancel the retrieval because it's not appropriate to go forward. But if they haven't, then we will go forward. So it really depends on what their reserve is, how old they are, at what size did they ovulate, and how do we know they ovulated early? Is it from a premature LH surge? And do we confirm it with actually an elevated progesterone post ovulation?
Okay.
Because some people have a higher baseline LH, but that doesn't mean that they had an early premature ovulation. So you actually have to confirm it that their progesterone rose and their estrogen dropped.
Okay. For someone with multiple failed euploid transfers that has a clean uterine workup, what would you do next? And at what point do you think it's time to move on to surrogacy?
Well, I don't know what the uterine workup you're describing. So does that uterine workup include a hysterosalpingogram? So even though we think that we're doing an embryo transfer and we're just looking at the uterus, we need to know whether or not the fallopian tubes are open and healthy. I always look at the images myself because
Mhm.
oftentimes the uterus, the tubes will be open, but they could be dilated. If it's dilated, it's associated with a 50% lower implantation and live birth rate and a higher miscarriage rate because it's called a hydrosalpinx. I also look to see is your uterus midline or deviated to the right or the left. If there's any question mark, obviously the uterus still has a potential space. So if you haven't had a hysterosalpingogram recently, I would also recommend a hysteroscopy where your surgeon will put in a camera inside your uterus. And I always look at the images. I want to know, even though your cavity may be pristine in that there's no polyps, fibers, or scar tissue, is there good perfusion? Is it uniform? Because I've seen patients where they actually have a bald spot where the cavity is pink throughout, but there's a clear bald spot, and that's why I'm not getting pregnant. The other things that we look for is there's 3 different mock tests out there. There's a Receptiva that looks at a biomarker for endometriosis. You can look for metritis. There is the ERA that looks at the number of hours of progesterone. But for someone with multiple failed transfers of euploid embryos or recurrent pregnancy loss, my go-to mock cycle is called the endometrial function test that I send off to Yale University. The reason I do that is that's the most comprehensive mock cycle where it's not just telling you one biomarker, but it actually tells you whether or not your lining develops, you will implant, you will have a live birth. It will also tell you whether or not you have the necessary proteins to implant properly and have a live birth, if you have endometritis or any signs of an inflammatory issue, or if you need a blood thinner. It also tells you if you have a high index of suspicion for endometriosis. If
Okay.
those things are positive, and someone does not have adenomyosis, I always consider them to an endometriosis surgeon. But clearly, if you're older and this is like your one precious embryo, in that situation, I would strongly always advise a patient to consider using a surrogate. The reason is you don't want to add any uterine factor when you only have one embryo, and to get another normal euploid embryo with your own genetics is really challenging. You don't want to waste that embryo.
Mhm.
So I always ask
Um,
patients, what's more important, carrying the pregnancy or having a
mhm.
genetic child? So if they have a normal embryo, sometimes for some patients, it's really like what's really critical to them is being able to carry. And they'll say, even if I'm not able to carry and all these tests come back abnormal, I just want to try. Other patients
Mhm.
will say having a genetic child is so critical that, yes. So I always want to know what is most critical to them, because I'm not
Yeah,
going to put people through the whole biopsy and mock cycles
right.
if they're open to surrogacy. But
No,
it's
that
not
makes
that
sense.
everyone needs surrogacy. You only need surrogacy really if we know you have known endometriosis. Not everyone with endo needs, it depends on where that endometriosis is affecting you. Sometimes it's the ovaries, sometimes it's the uterus. So obviously if it's the uterus, that's when we talk about surrogacy.
Okay. And since we kind of brought up that donor thing, how do you to people about using an egg donor? Do you do it based on more where they are mentally and they want to just give those shots, or do you give them more stats and like as logistically and factually?
So it depends on a lot. So it's not even age-based because I do have some young women who go into premature brain failure. So it really depends on a couple of things, right? So if you're young and you're going into premature brain failure, what I look for is when we do an IVF cycle, was there any sign of a post-mature egg? Did you, no sign of a post-mature egg? We triggered you properly, your estrogen rose post-trigger, you fertilize well, and nothing is growing, and you don't make a blastocyst, and we trigger you smaller and you're still not making a blastocyst. In that situation, if your eggs are atretic, then at that point you really have to consider using an egg donor, because oftentimes we can get you to a blastocyst, but whether it's going to be genetically normal or not is dictated by nature. But for some patients, the eggs will not even make that embryo into a blastocyst. A blastocyst, you'll know if it's an egg factor or a sperm factor because every embryo, half the DNA is sperm, half the DNA is egg. So if you look at the embryo and it's atretic and it doesn't even become a day 5 embryo, that's more of an egg issue. The genome of the sperm comes into play on day 5, 6, or 7. So I always like to make sure was the sperm as perfect as possible because the life cycle of sperm is 2 to 3 months. So before I will even start the first IVF cycle, I'd like to make sure that the sperm is optimized as much as possible because I don't want to do a cycle if the sperm's not there. Then if you're making embryos and embryos are just not making it, we can't get a blastocyst to save our life, I really have patients consider egg donor. The hardest time to consider egg donation is when patients make beautiful blastocysts, but they're just not genetically normal. And that we can only help you make the blastocysts, but whether genetically normal or not, that's dictated by nature.
Yeah.
So, we really have to figure out like what is our next step. And that's the hardest part is when people make lots of blastocysts, but they're just not normal.
Yeah. And then in terms of that, narcissist and normal, would you ever consider transferring low-level mosaic?
Absolutely. So if we have low-level mosaics, what I have found is that I treat the low-level mosaics almost like a normal embryo because I've had so many healthy live births. I always have patients consider like they have to meet with the genetic counselor first just to be counseled. We transfer the low-level mosaics and we tell them that when you're pregnant, you need to do an amniocentesis, not a CBS, but an amniocentesis so that the actual cells for the pregnancy are checked from the fetus to make sure is it normal or not. And I mean, knock on wood, to date, I haven't had one low-level mosaic embryo transfer that's resulted in an abnormal embryo that or a fetus that required a termination. They've all gone to healthy pregnancy. So I really do treat low-level mosaic embryos. The other one that I will consider that people, don't always think about are the segmental defects. When it's a segmental, I have them meet with a genetic counselor, and the one I like is Amy Vance in Northern California. She does virtual consults. And what she will do is there's actually maps of everyone's chromosomes, and she'll tell you whether or not where you have that defect, is it in a clinically relevant part of the chromosome that is expressed? Because if it's not, I've also had really healthy pregnancies for those. So I always like to make sure with every embryo, did we do our best to ensure that this is not an embryo that has a chance of a live birth?
I mean, that's really encouraging, I think. Do you also recommend a fresh transfer if it's someone maybe who's a poor responder over 40?
Well, you can't do a fresh transfer when you're doing any type of genetic testing because you
Hmm.
have to freeze the embryo, so there's no fresh transfer. The only way you could do a fresh transfer is if you're doing a second IVF, and after the egg retrieval, you're transferring a tested embryo from a previous cycle. 5 days after the egg retrieval, I've done that. If someone ovulates properly, I really like to do a natural FET where I just monitor their natural cycle and then ovulation and transfer several days after a trigger ovulation. I really feel that if someone is ovulating well and there's no uterine factor, that's oftentimes what I prefer. Or if someone's had secondary infertility where they've had no difficulty having baby number one, then I really feel that it's a proven uterus. They just oftentimes not having a genetically normal embryo. So when we have that normal embryo, I like to do a natural FET.
Okay. But so if for in this case, person, if they don't want to necessarily test because they don't get very good results, and to just try it either fresh or I guess frozen beet testing, would you do fresh, like right out of the
Could do a fresh, but I will tell patients these are the biggest concerns. If you're older and you're doing fresh, first of all, we only do it on day 5. We don't do day 3. We don't even look at embryos on day 3. What we found is that by leaving embryos alone from fertilization to day 5, not changing temperature, gas, pH exchange, embryos just do better. You don't want to go through the motions of simply doing a transfer. So if you have a high quality blastocyst that's untested, I will consider doing it on day 5. But here are the downsides. The downsides are if you're not pregnant or you have a miscarriage, we don't know what the abnormality was oftentimes. So we don't know what would we do differently. Number 2 is if it doesn't result in a pregnancy, we don't know, was it your uterus or was it the embryo? But the most devastating is when it does take, but it doesn't result in a live birth, you can oftentimes lose 3 to 4 months. So if there's like one abnormality, oftentimes those actually will implant, but the loss can happen later after the first trimester. And in that scenario, patients lose about 4 months at least. And when that
Right.
happens, it's a critical time if you're older with diminished ovarian reserve.
Right, that makes sense. Thoughts on supplements? Do you ever recommend any, and if so, which ones?
So I like obviously prenatal vitamins. I like Ritual or Thorn. Someone has a lower ovarian activity or their activity is not active, I really recommend working with acupuncturists that I work with often. I think acupuncture in the right hands can be really helpful. I do a lot of lifestyle changes that I think are really important, going to bed before 11 p.m., doing high intensity workouts, obviously avoiding any cigarettes, pot, or vaping. No alcohol. So the reason for alcohol is not bad for your eggs, but when you drink, it disrupts your REM, then it prevents you from ovulating properly. So those are the lifestyle things I like to do. And I don't like hot yoga or high intensity workouts. For the other supplements, if someone has a low reserve, I'd like ubiquinol, which is the coenzyme Q10, and it's a formulation that absorbs a little bit better than the ubiquinone. And I like that in addition to the herbs of the acupuncturist. But that's it. I know that a lot of times patients will come with like a whole bag of supplements. You can't swallow a pill. It doesn't go straight to your ovaries, so I don't really believe in that. I really believe that less is more.
How about immunology, like getting immunology testing?
Well, there's a definite role for it. If you have an autoimmune issue, or when we do the endometrial function test, if you have inflammatory cells, or have a later loss, if you have a second or third trimester loss, 100%. It's not only an immunology, but also a thrombophilic workup because the blood flow between the placenta and the uterus occurs after about 14 weeks. So if you have an early loss, that's not really high on my list. If it's a later loss, 100%. I would have you see a high-risk specialist. We would do immunology. We would also do a thrombophilic evaluation.
Okay. To clinic shipping, is it truly safe?
So we don't accept outside eggs and embryos. So I'm not sure what you're talking about clinic to clinic shipping.
Yeah, that's what I meant. So you don't ever accept any outside ones?
No, I mean, on rare occasion, I've made an exception, really rare. I always feel
Okay.
that whenever you have eggs,
Mm-hmm.
always thaw your eggs where you had them done. Because eggs are not like embryos. This is something that was experimental for many years. Every center did it a little bit differently. They use different media. So if you want to give your eggs the very best chance, always thaw them where you made them.
What if they are
Embryos, like there are a lot of times where people will biopsy things that we don't touch,
mm,
and there's like variability. So I just don't accept outside embryos.
okay,
But if you
fair.
did use them, oftentimes we have patients who come from international and they have to ship the embryos
Mm,
here because
hmm.
of surrogacy is not available where they
Right.
are. They need a
Hmm.
surrogate. I've had patients without a uterus or they've had cancer. In
Okay.
that situation, there are courier services that I recommend. There's one called Kinesi, and what they do is they actually will courier and walk it through airport because
That's
it's
great.
so precious. You don't want it to
Yeah,
be
of course.
in storage.
Yeah.
Yeah.
Okay. What are your thoughts on GLPs, GL1s for several months before moving forward if your BMI is high?
To carry or to do IVF?
I'm not sure, but how about we go with both?
Okay, for IVF, the drastic weight loss, what I have seen, like when Ozempic first came on the scene like several years ago, everyone's ovaries shut down because it was basically going into starvation mode. And so when that happened, I had a lot of patients come back from the summer, like they were in the Hamptons, they all like lost a ton of weight and their ovaries completely shut down. And I had to wait 3 to 4 months after Ozempic goes off for their ovaries to recover. And so that's with any starvation, or that's why I asked like no high intensity workouts. Because if you do
Mm,
rapid weight loss, your ovaries will shut down because your body's in starvation mode. It's trying to
hmm.
preserve itself. But if you do a very gradual weight loss and it's done under the guidance of a doctor and it's totally appropriate, and I've had good experience with Mounjaro, I think it's great. And especially if you have a lower BMI, oftentimes you're can be more responsive. So if you were on the upper end of a BMI of like 40 or 45 and you're getting lower, I've seen patients actually conceive naturally because they're now ovulating on their own,
Mm,
will have better ovarian activity. For eggs, it makes a difference if which one it is, how rapidly you're losing the weight loss, and why you're doing it. If you're doing it because you're diabetic, if your BMI is really elevated, if your ovaries have shut down. For embryo transfers, I recommend that you stop it at least 2 months before. But with anyone with an embryo transfer, I really strongly have them consider trying to get to a healthy weight before they try. So we know that elevated BMIs are associated with lower implantation, higher miscarriage, but also more importantly, higher obstetric risk. So it's not about weight, but it's really about having
yeah.
a good obstetric outcome. So I do work with nutritionists, and so
Yeah.
they will help you in both fertility and pre-pregnancy and pregnancy, so that it optimizes us on so that they can have a healthy pregnancy.
Mhm. I wanted to see, would you be open to answering some of the questions that have came through while we were talking?
Of course.
Okay. So one person said, I remember having estrogen and progesterone labs prior to retrieval, but no labs prior to transfer. Should there be labs happening, not just the ultrasound prior to FET? If so, which ones?
Okay, so it depends if it's a medicated cycle or a natural cycle. So if it's a natural cycle, 100% you need an estrogen, LH, and a progesterone. The reason in a natural cycle you need that is you need to know when that progesterone rose, because that's when we do the transfer. If it's a medicated cycle, I usually recommend, unless someone's 100% sure that you did not ovulate, that you should at least have an estrogen progesterone. The reason for that is you just need to know that your body, you haven't tried to ovulate through the medications, because if you ovulated through the medication, whenever we do a transfer, it's based on the number of days of progesterone rise. So if your progesterone already rose prematurely because you ovulated through the medications, that would affect implantation. So for an embryo transfer, at a minimum, I do recommend an estrogen progesterone. If it's a natural cycle, an estrogen, LH, and a progesterone, because you want to know if your body is surging. And if you're surging, then they may want to move up your transfer. Because even if it's a medicated cycle, some people have ovulated through estrogen.
Okay.
So what estrogen does, it's supposed to prevent you from ovulating, right? That's the whole point of it.
So if it's too low.
Someone has a lower ovarian reserve or older, we have had patients where they've ovulated through
Okay.
the estrogen and it was early, so you didn't see the change in the lining, where you have the the trilaminar
Yeah.
lining.
Mhm.
If it's later on, you'll see the change in the lining. But if it just happened like the day or that day or the day
You
before,
wouldn't
you
know.
won't see that change, but it would have, you're not going to get pregnant.
Okay.
So real.
Somebody asked about lining. Ideal lining, she, I guess, said was told 7 or 8. If it's one, question 2 is there a number that's too thick? And actually, it's interesting because I just read a study in fertility and sterility that was saying ideal is 12. What are your thoughts?
So I think there's a big range. So it's not just about the lining. So what you want to look at is not just the lining, but the lining, the contour. Does it look like the end of a Q-tip in both directions? So in when you're in sagittal, does the end of the lining look like a Q-tip? Are there any black circles, like little black lakes in the muscle? Then that's not ideal. Then you always want to make sure you look at your uterus 90 degrees and does it look like a pair of lips? If it doesn't look like a pair of lips and there's a break in it, that's not ideal. So to me, it's not just lining thickness, but it's the pattern and the contour of the lining. That's really important to me. And that there's no other signs of something like adenomyosis, which are the lakes, or any fibroids that are budding the lining. But to me, for the lining, if you're asking, the pattern to me is more important than the actual thickness. At a minimum, there are some studies that show that even a thickness as low as 5 to 6 millimeters is fine, as long as you have the trilaminar pattern. For myself, I like to have 7 to 12 millimeters. I don't like it too thick.
Mm.
Because if it's too thick, I always worry, is there a flat polyp or not?
Okay. Is the strategy for women with high FASH or no longer have regular periods due to perimenopause?
And how old are they? I don't
How
know.
old are you? In the chat, how old you are. Her second question was, what are your thoughts on the new Chloe embryoscope?
So I don't think that we're anywhere near for any of the embryoscopes. We don't do that. The reason
Okay.
is it's the number of hours that, and no one has done the AI to look at all the images. And so they have to like specifically look at certain hours. So we have, even when I was at Cornell, we were looking at the embryoscope, we looked at a lot of different monitoring systems. Now with the advent of AI, I think that people are going to be looking and examining all the images to see if there's any correlation, but at this point, there is no correlation. So I don't think it's going to be clinically relevant at this point yet. I think that we're going to get there, but we're not there yet. So I don't believe in any of those monitoring systems. In terms of FSH, if someone has a history
She's
of
37, by the way.
okay, so it depends on if they have a lot of follicles or not, if they're synchronized. So if they have a history of an elevated FSH, I know that oftentimes they may not ovulate properly on their own. The reason is when you have a high FSH, your body tends to have a higher baseline LH. Problem with that is when you have a higher baseline LH, then your body your LH never surges enough for you to release that egg properly. So you're not going to ovulate properly. So you, at a minimum, you want to be monitored and to trigger ovulation. Then after ovulation, remember how I told you that's when I synchronize because you can see the follicles for the following month. So in someone with a high FSH, that's when I synchronize, whether it's with estrogen patches and or antagonist. Then when they start their cycle, if they're not pregnant, if their FSH is already higher, the medications we use are FSH. I'm not going to give them shots. I'm not going to give them Gonalab or Follistim. I'm not going to give them Clomid because they already have a own elevated FSH. What I like to do is see whether or not their follicles will respond to their own FSH. So if your FSH is already high, it's like you're taking an injection like Gonalab or Follistim, and I'll follow you closely to make sure are the follicles growing together. And if they are, at that point, when I have to add the antagonist so you don't ovulate, that's when I add Menopur only. And then I always trigger smaller. I really believe in quality and triggering smaller, especially with the history of a high FSH and a lower reserve.
Okay. And for that person who to know about testing estrogen and progesterone, when would you do that medicated transfer cycle? When would you
Always before you start the progesterone. You have to do it before you start the progesterone. So you do it mid-cycle when you check the lining. When they say, okay, this is where we're going to start the progesterone, you're going to start the progesterone tomorrow at 12:30, and then 6 days later, you're going to have the transfer. When you are there for the ultrasound, that's when you check the estrogen and progesterone because you need to know that your progesterone is low and that you can start the patients without any issues.
Okay. And then last question from the group, and then I have two of my own. What do you advise for patients with diffuse adenomyosis?
Okay, that's a really hard question. So you have to see where is it located? Is that the fundus where implantation occurs 80% or not? Is it abutting the lining or not, or is it in the muscle or near the surface, right? And then you also need to know whether or not it's, it's diffuse and they have how old they are and how many embryos they have. So if it's diffuse and the color flow Doppler, when you put the light on for the blood flow, is inactive, then that's something you can say, okay, you have it present, but it's still early and it's not active. So what would be my key scenario? My key scenario is if it's away from the top of the uterus, called the fundus, where implantation occurs. You put the color flow Doppler on, it's not active, and it's very focal and away from the lining. I'd say I would try it. If there's any activity or it's near the top, then I would do the endometrial function test to make sure, do you need a medication called Depo-Lupron, cut you down and put you into a temporary medical menopause. I know that sometimes patients like to just use that Depo-Lupron across the board. And so that's another option where you can put yourself into a temporary medical menopause. But if you are younger, it's very symptomatic, or if you want to be able to do IVF again, you won't be able to do IVF again because it's unpredictable. I don't know when your ovaries are going to wake up again. So it's something that I'm very careful about. So again, when you have the adeno, not everyone with adeno needs a surrogate, but you have to know, is it active with the blood flow? Where is it located? Is it focal? And is it near, and is it touching the lining or not? If it's not touching the lining, it's not active and it's not near the top, I would feel really comfortable doing a transfer. If, however, it's at the top or the blood flow is really active, that's a time that I would have a more serious conversation.
Okay. And then now for my two lighthearted questions. If
Okay.
you had to swap careers for a month and you were already amazing at it, what would you choose?
If I had to swap careers right now, what I would do is I would actually work in a German Shepherd dog rescue. So that would be like my dream.
Someone else said something about working at a doggy daycare, I think. This is so
Oh,
funny.
really?
Yeah.
Yeah, no, I would work for a
I
German
think it was
Shepherd
Dr.
dog
Park.
rescue.
That's so funny.
Oh,
Um,
Susanna?
yeah, yeah.
Oh, is she into dogs too?
Yeah, so
Oh my
yes.
God, yes, I would totally run because
Ah,
I just feel like German Shepherds get a bad rap and there's such a bias against them. And, they're just such sweet dogs.
oh.
Yes.
Second, do you go to bed with your email inbox at 0, or are you one of those with that thousands of unread messages and that little icon in your corner?
Okay, so we don't do email because it's not HIPAA compliant. We just do the portal messages, but I always end the day with my portal messages and everything at 0. And so
Okay.
then if patients, we only check it during office hours. So I finish the day and make them 0. But if obviously patients put it in after hours, then I wake up and when I go into work, I'll see them. But it does go to 0. But we don't do email overnight because
Got it.
Yeah, it's not
Well, how
hypocritical.
about your personal though? How about your personal email? Zero, or you all cleaned up or
Oh,
no?
personal email. You know what? What's really great is I don't email people. Everyone, I just call and text.
Oh, okay.
Yeah.
Okay.
So like for yours,
Very
when you're
cool.
sending me the link, I had to like
You're
specifically
like,
look.
oh, how do I find my password?
Yeah. So I actually don't have, you know how some people on their phone will have an app for their email? I
Yeah.
don't have it. I actually
Oh
have
my
to go
gosh,
log
really?
in. Yeah, no, I don't. So I actually have to log in. So for this link
Oh my
today,
God.
I had to like actually go on the desktop, log in to do it.
This is definitely the best fact, and not have an email icon is iconic, really.
Do you all the time and do you go to zero?
All the time. This
So
is such nice. You are such a lovely person. Thank you so much for doing this. I know that everyone benefited. I think everyone is
oh,
very
my
grateful for
pleasure.
you coming on and answering these questions.
Thank you so much for having me.